Shall I start, sir?
Yeah, go ahead.
So my topic is on anesthesia for elective Lscs. So first to go on with the indication of elective Lscs, it can be divided into maternal and fetal. So the maternal indication be like previous Lscs, classic absolute. If it's a classical cesarean section, then absolute, and if it's a lower segment, it's a relative indication. And then previous myomectomy and placenta previa, infections like maternal HIV, primary herpes, previous vaginal surgery with pelvic organ prolapse or third or fourth degree perineal lacerations, dystocia like abnormal pelvic configuration, pelvic deformities, soft tissue dystocia, everyone says, and vaginal septum or cervical cancer. The fetal indication includes fetal growth restriction with fetal compromise, twin pregnancy like first twin non-cephalic, and a mall presentation like breech or transverse presentation, macrosomia and fetal anomalies, severe hydrocephalus, and stillbirth and any previous perinatal events. So these are the indications for the elective Lscs. Before going into the thing, normally what are the anatomical changes in the pregnancy that we should be worried before giving a neuraxial bracket. So anatomical changes can affect the neuraxial techniques. So uterine enlargement and vena cava compression. There will be engorgement of the epidural veins. So there will be accidental intravascular epidural catheter cannulation can occur, and then it may also displace the CSF from thoracolumbar region of the subarachnoid space. So only in the pregnancy usually lower the dose of the requirement of the spinal anesthesia. And then ligamentum flavum, which you are piercing the neuraxial blockade, can be less dense, softer in pregnant women than in non-pregnant women. And one more thing is to difficult to achieve flexion in the lumbar spine. So the major three changes: pregnant woman pelvis rotates, so the Taffius line may corresponds to L3, L4 rather than L4 to L5 interspace, and then less between the adjacent the lumbar spinous process during pregnancy. So only it's like it will be felt like a narrow space. And then third point, lumbar lordosis can be there. The lumbar lordosis shifted the caudal spread of the CSF during the pregnancy. So this changes leads to influence the spread of the anesthetic solutions, leading to higher sensory level in the patients. So normally, in the first stage of the labor, pain from the lower uterine segment, cervix will transfer to T10 to L1 segments. In the late first stage and the second stage of the labor, distension of the pelvic floor, vagina, and the perineum usually occurs. Through the somatic nerve, it transmits to S2 to S4 segments. So, usually in LSCS segments, additional nociceptive pathways should be involved in the transmission of the pain. So the level we are achieving is to T6 to T4 level is required. Most LSCs, they are giving the phalansteal incision, that's the infraumbilical T11 to T12. So the stretch of the skin, usually we are keeping the sensory level 4 to 5 levels above. Then the physiological changes in the neuraxial blockade includes hormonal changes, anatomical changes, decrease in CS of specific gravity. It decreases the anesthetic dose requirements in our neuraxial blockade. And then local anesthetics produces conduction blockade by blocking the sodium channels in the nerve membranes, preventing propagation of the nerve impulses. So usually spinal anesthesia, the mechanism of local anesthesia will be on the spinal cord, whereas the epidural, which you are providing in the labor anesthesia, the action of the local anesthetic will be on the nerve tissue within both epidural and the subarachnoid spaces. So for the elective LSCs, usually the OT preparation should be made, proper preoperative assessment should be taken, and according to that, the OT preparation should be made. Anesthesia workstation should be checked, and the GA drugs with the medicine should be kept ready. Medicines basically include oxytocin, atropine, ephedrine, methergine, carboprost, propofol, ketamine, midazolam, naloxone, calcium chloride, and sodium bicarbonate. ET tubes, bougie, stillate, everything should be made. Laryngeal masks with appropriate sizes, airways, Goodell's airway and nasopharyngeal airways, and then laryngoscopes and assorted blades, suction source, oxygen source, and CO2 detector should be made. So usually in LSCS, we mostly prefer neuraxial blockade, so most common spinal. If there is there's any chance of failed spinal, or if there is like PPH, or there is a need to convert the patient to the general anesthesia. So mode of anesthesia is most commonly used is spinal anesthesia. So before proceeding with the neuraxial anesthesia, inform consent, patient procedure, and complication following the neuraxial anesthesia should be explained to the patient and also the attendants. and the proper consent should be obtained for the neuroaxial thing. And there we should also check for any contraindications for performing the spinal anesthesia. So the spinal anesthesia contraindications are two types, absolute and the relative. If it's absolute, the patient refusal, local anesthetic allergy, any sepsis or ongoing any infection in the local area, like where we are injecting. And then relative is bleeding diathesis, and then cardiac diseases, increased ICP where there can be herniation of the brainstem, and then continuous patient is on continuous anticoagulants. So before induction of the neuroaxial anesthesia, when the patient is getting shifted to the OT, all patients are advised to monitor BP and pulse ox and ECG. Everything should be connected. FHR also the FHR pattern should be monitored by the qualified individual before and after administration of the neuroaxial blockade. So patient positioning, usually pregnant women will have exaggerated lumbar lordosis. So it's difficult to flex the lumbar spine. So it can be given in the spinal anesthesia can be administered either in sitting position or the lateral position. Usually the advantages of the lateral position is that orthostatic hypotension will be less, and then position often facilitates controlled FHR monitoring using while placing even an epidural catheter in the labor and delivery. And then sitting position is preferred usually in the obese patients for the because the identification of the midline will be easy compared to the lateral position. And obese patient when positioned in the lateral hypoxemia can occur sometimes. So there will be greater decrease in the maternal cardiac output in the lateral decubitus position than in the sitting position. And the maximum lumbar flexion in the lateral decubitus position can also lead to iotocaval compression. But in the compared to supine, lateral is better because supine position can lead to supine hypotension syndrome also. If the maternal hydration is inadequate and if the iotocaval compression is there, anesthesia like spinal anesthesia what we are giving can lead to sympathetic blockade, will further cause decrease in the venous return, decreased cardiac output, and the decreased uteroplacental perfusion. So before giving spinal, the procedure should be done under strict aseptic precautions, proper scrubbing and the gloves, appropriate size gloves, and the gown has to be weared. And the patient's back has to be painted with a betadine solution and should be cleaned and draped. And then, so spinal anesthesia usually we're giving using Twinkie or Whittaker needles. So Twinkie is like cutting type of needle, and then it's usually there's an increased chance of PDPH after the Twinkie needle, whereas the Whittaker is a non-cutting type of needle, which will split. So the chance of decreased PDPH will be there. So usually as in elective anesthesia, elective procedures, you can use 27 gauge needles. So the gauges will decrease, reduced chance of PDPH will be there. If it's an emergency or a fetal compromise, you can go for a larger like 22 gauge, 23 gauge needle because you can feel the space easily and you can find it out. If the smaller needle, 24 gauge or more is used, introduce a needle is performed. And so, and the approach for the spinal anesthesia is either, so first is the position is whether sitting or lateral, and the approach is whether midline or paramedian. So the midline approach, patient should reduce her lumbar lordosis to enter the subarachnoid space. So palpate the interspinous process to identify the space. Give local anesthetic first. So our skin is the most painful part. We should form a proper bleb in the skin, like intradermal, and then to the subcutaneous. So it will reduce the pain. And the using space or needle not in the if this is a wrong space or the needle is not in the midline, patient will complain of the lateralizing pain and the lack of CSF flow despite normal length of the needle will be inside. So if the needle is into the CSF space, free flow of drug can be seen, and then you can aspirate whether to confirm whether it's in the space, and you can give the rate of 0.2 ml per second. So midline approach is faster, lesser painful. Midline approach is better in obese patients because patient not needed to reduce their lumbar lordosis. And during performance of this nerve block technique, if patients complains of any pain, we should stop the procedure. If the pain or paresthesia due to inadequate soft tissue anesthesia can also be due to needle contact with the central nerves or the spinal cord. Sometimes the spinal cord can also get injured. So patient if complaining of paresthesia, during initiation of the spinal anesthesia, the needle tip is in the subarachnoid space. When the free flow of CSF is seen at the tip, it's like it's in the proper space, and we can aspirate and we can give the local anesthetic. If the paresthesia is not resolved even after the thing, we should reposition the needle and to check the proper space. So choice of the drug is usually use the hyperbaric solution compared with the plain solution without dextrose because it provides faster onset of block, high maximum sensory level with shorter duration of the blockade. So usually additives to the hyperbaric solution, we usually use opioids to improve the quality of the anesthesia and post-operative analgesia. It can decrease the incidence of nausea and the vomiting. So this is about the neuraxial anesthesia. If we are not able to continue the case with the neuraxial anesthesia, if there is any PPH or there is any failed spinal, is there chance to convert the patient to the general anesthesia? These are the requirements in the general anesthesia. Usually MPC will be increased to 4 if by 34% by 12 weeks and 38 weeks. And vascular engorgement of the airway will be there, results in the edema of the oral and the pharynx. There will be difficult in the intubation and the difficult in the mask ventilation. Airway edema will be there. Patient can also has URA and preeclampsia if the patient is pushing for the long time. And pregnant women will become more hypoxic because FRC will be reduced and there will be increased oxygen consumption will be there. Dehydrogenation is achieved faster in the pregnant woman because of the increased minute ventilation. And then safe apneic time in pregnant woman is usually 2 to 3 minutes despite pre-oxygenating for more than 3 minutes. So ventilation, PaCO2 of 30 is achieved when the minute ventilation of 121 ml per kg per minute. So normally RSA rapid sequence induction is done in the patients with the pregnancy because we are considering pregnant patient as a full stomach always, even though they are telling you the adequate NPO protocol. Because of the uterine distension and there will be the pushing of the stomach, they will be considered as a full stomach patient. So we are doing RSA. Usually are inducing the patient, and then before giving the muscle relaxant, we first will pre-oxygenate and then induce the patient, and then we are not bagging mask because the bag and mask can lead to the aspiration. Then we are applying a cricoid pressure. Then we ask muscle relaxant and we're intubating the patient with the appropriate ET tube. And then next, after the intubation, we are releasing the cricoid pressure to prevent the aspiration. So normally the inhalational and the intravenous agents which are used in the pregnant patients for the general anesthesia, it is reduced compared to the non-pregnant patients because propofol requirement first is normal commonly used induction is propofol. Its requirement is decreased by 10% the first trimester. Elimination half-life is unaffected, and then the rate of the rise of alveolar to the inspired anesthetic concentration ratio is like the speed of induction will be increased because of the greater minute ventilation and the decreased efforts. That is, the uptake of the inhaled anesthetics will be more. Normally, in the minimum alveolar concentration, it's 40% lower in the pregnancy compared to the non-pregnant females. And then coming to the muscle relaxants, pseudocholinesterase activities will be reduced by 24% by delivery and 33% by the third postpartum day. And it will become normal to 2 to 6 weeks postpartum. So this like pregnant women are less sensitive to succinyl choline than non-pregnant patients. This is one of the advantage that there will be rapid, usually in rapid sequence induction, we are giving depolarizing muscle relaxant because the onset and the duration will be low. So the because of the pseudocholinesterase thing, the rapid recovery from the succinyl choline will also be there. To enhance the sensitivity to aminosteroid muscle relaxants like vecuronium and rocuronium. So pregnancy reduces the chronotropic response to isopretinol epinephrine because of the down regulation of the beta adrenergic receptors. So usually after the spinal anesthesia or something, the chance of hypotension, which should be treated with the higher doses of the phenylephrine because of this down regulation of beta adrenergic receptors. Then as we are inducing with the patient with the general anesthesia, there may be some drugs which can transfer, placental transfer of drugs to the fetus. So placental permeability pharmacokinetics determines the fetal exposure to the maternal drugs. So the factors which are affecting the drug transfer are lipid solubility, protein binding, tissue binding, PK and pH, and the blood flow. So high lipid solubility may readily enable cell membrane penetration, but may also cause drug to be trapped within the placental transverse. So what are all the drugs that readily crosses the placenta are atropine, scopolamine, beta adrenergic receptors, and nitroprusside. What we commonly use midazolam, propofol, ketamine, etomidate, thiopentone, dexmed, and the inhalational agents like sevoflurane, isoflurane, desflurane, and nitrous. Drugs that do not readily cross the placenta are glycopyrrolate, heparin, and succinyl choline, sugammadox, and phenylephrine. So these are the drugs that do not readily cross, but these are the drugs which will cross the placenta as soon as possible. So there is like a fetal maternal ratio depends on which the drugs we like everything will cross as the placenta answer.
Finished?
Yes, sir.
Okay. That was a fairly well structured answer, but there are a lot of lacunae in that. When you mention about the lateral position for giving a subarachnoid block in a pregnant woman, what is Oxford position?
Oxford, sir.
Have you heard of Oxford position? I think I showed the picture in one of the earlier discussions. How to position the woman, especially I think in the first discussion about changes in normal physiological changes in pregnancy and its implications in anesthesia. I think I showed the picture. You were concentrating more on the lumbar lordosis causing narrowing of the interspinal spaces and difficulty in doing the spinal. But
Yes,
what precautions you take to prevent a very high spread of the spinal? You need, of course, a level up to T4 or T5. But in pregnant women, especially in the lateral position, if you don't take proper precautions, it can spread even beyond T4, above T4, and become almost like a total spinal, especially if you are not careful about the volume and the speed with which you inject the drug. So what do you do to prevent that? You do what is called the Oxford position by giving a pillow to the mother's shoulder and the head area so that the head end is elevated. Okay? So that the thoracic curvature will be angulated in such a way it cannot spread more than T4. Okay? There are pictures available in the net and even the books you have that. It's called the Oxford position, which should be mentioned if you are talking about the lateral position for spinal subarachnoid block in pregnant women as a routine technique for elective cesarean section. And elective cesarean section comes under what category of cesarean section? We were earlier talking cesarean delivery only on two terms, emergency and elective. But nowadays we talk more in terms of category of cesarean section. How many categories of cesarean section are there? And who classified like that, and what is the importance of that? Elective cesarean section comes under category 4. There are 4 categories: category 1, category 2, category 3, and category 4, as classified by Lucas et al. This is mainly to hurry up the time, especially when you say it is a category 1 cesarean section. It means there is an imminent threat to the life of mother as well as the fetus. Okay? So it is like a combined fetal distress and maternal distress. In such conditions, when it is declared as category 1, the baby should be delivered within 30 minutes of declaration that it is a category 1 cesarean section. So everybody should be alerted. Patient should be moved to the theater, anesthetist, physician, neonatologist, nurses, ward boys, blood bank, everybody should be alerted, like a code blue or the signals that you give when there is an emergency. Like that, for a category 1 cesarean section, the delivery should happen within 30 minutes of declaring the patient as a category 1 cesarean patient. Category 2 is a slightly, you have a little more time. There is no immediate danger, but it is to be done quickly. Category 3 is a little more less serious. And category 4 is what we routinely call as elective, which is to suit the convenience of the patient, the surgeon, the anesthetist, everybody. So you can decide when you want to do that. So when the question is worded as elective, cesarean section, first thing you have to mention is it comes under what is called the category 4 cesarean section. And as I said earlier, nowadays the anesthesia of choice is regional technique, especially single shot subarachnoid block, because of the ease with which you can perform it, and majority of the surgeons are able to finish the surgery within the duration of the block, which can be affected, especially with bupivacaine. It can last up to say 2 to 2.5 hours also. So majority of the surgeons are well trained to finish the surgery within that particular time. And the second problem which you mentioned about obesity, you said the sitting position is better because there will be less desaturation, as you rightly said, compared to the lateral position. But there may be difficulty in identifying the midline. So what are all the techniques by which you can identify the midline in a morbidly obese mother who is who is waiting for a subarachnoid block? How can you identify? Sometimes, you know, you see pictures of the back of women where the fat is folded and flowing all over. So there is no way you can identify. Even the scapula is not seen, and the spinous process is very difficult to palpate when you even press hard. It is very difficult to identify where exactly the spines are coming. So what is the equipment that you can use to identify the spinal in a morbidly obese mother? Ultrasound is being increasingly used. But one practical tip I learned from the listening to a lecture by one of the obstetric anesthetists. What he did was he was using a cold swab. You always have spirits available in the theater to clean the skin. So you dip the cotton in spirit and start touching from one side or right side or left side, and then come close to the midline, and then ask the patient to say yes when they feel the cold sensation. When they come to the midline, supposed midline, you just stop it there, and then on the other half, he said you can just start coming from without a cold saline. You come from with a swab. You come from the other side, and that line where she is able to identify the cold sensation, that is the point you can easily identify. Very simple method of identifying this midline, especially in very obese patient with a lot of fat in the back. Okay, so if the patient is able to identify that position, they will say it is on the right. Then you come. Now they will say I am feeling it on the left. Then that is the junction where you can immediately identify the midline if you don't have an ultrasound guidance. Okay, so these 2 points you can add to your answer: Oxford position for lateral positioning and midline identification in obese patients, and of course the chances of hypotension after spinal is more. So preloading and co-loading are the 2 words that you have to use about fluids. So if the patient does not have any cardiovascular issues, then you must always either preload the patient or co-load the patient as you are giving the spinal, so that you can avoid or prevent the sudden hypotension that can happen. And always remember to keep the Crawford's wedge or the left lateral tilt, so that the supine hypotensive syndrome does not aggravate the hypotension that commonly happens with the subarachnoid block. Then coming to the general anesthesia, you mentioned about pre-oxygenation. You can mention the techniques of prolonging the safe apnea period, like supplemental oxygen through the nasal prongs, or high flow oxygen, or the other things, at least a mention of all those the newer techniques with which you can prolong the safe apnea period also can be included in your answer. And whenever you talk of GA for cesarean section, you have to talk about what is called induction delivery time. That is a very important point in GA, because you must deliver the baby. So you normally for GA for cesarean section, we allow the physician to paint and drape and keep the patient ready, and then we start inducing so that we don't waste time to paint and drape after induction. So usually the practice is to allow the patient to be draped and painted and draped, and then we start inducing so that as soon as we say the tube is in and every parameter is okay, the surgeon will make the incision, and ideally it is done within the first 5 to 10 minutes of induction, so that all the drugs that we give do not cross and go to the fetus and cause a depression in the fetus. So the induction delivery time is very important. So that should always be mentioned in your answer. And the precautions you have to take, apart from the pre-oxygenation, you always have a spare laryngoscope, because sometimes the laryngoscope you are using may not burn after you put it inside the oral cavity. So it is always better to keep a spare laryngoscope. You must have a separate section for the anesthetist, because the regurgitation and vomiting is more common, as you said, full stomach problem. Even in elective, well starved or well fasted patient also can happen. So you must have a separate section for yourself. And the patient, the table, the operating table should have all the facilities for tilting the head end or the foot end, so that in case of hypotension, if you want to give a head down tilt, you should be able to do it so that you can correct the hypotension. So all this paraphernalia and all the routine monitoring, including ETCO2, should be there. And with regard to succinyl choline, I think you said it action is rapidly washed out. I don't think so, because there is a dilution and the cholinesterases are low or diluted in the plasma. The action of succinyl choline is actually prolonged when you give it for rapid sequence induction. It is not cut short. So so sometimes you may get a doubt whether the patient is going in for scoline apnea, because they take longer time to come out of the scoline. So you are scared to give your non-depolarizing relaxant without the especially if you don't have a nerve stimulator, you always have a doubt whether the patient is going to come out and breathe normally or not. And while you are waiting, suddenly they may buck also. So that is always a dilemma that you have. And I don't think it is shortened or they are more sensitive or something like that. So that point also you have to mention in your answer. And with regard to analgesia, when you give general anesthesia, I think you have not mentioned anything about the drugs that you use for analgesia intraoperatively. So paracetamol can be given safely right from the beginning, but any opioid has to be given only after the delivery of the fetus in general anesthesia. Okay, so that point also you have to mention, right? So with that, I'll just show a presentation.